Hi, everyone. I'm Anu Navani. I'm the Chief Medical Officer of Boomerang Healthcare. And with me, we have Erin Hernandez, who is very deeply involved with functional restoration program at Boomerang Healthcare. At Boomerang, we offer multiple services for patients with spine, orthopedic, and musculoskeletal pain conditions, starting from interventional treatments to minimally invasive surgery to rehabilitation programs, such as functional restoration program, trauma rehabilitation program, traumatic brain injury program, work hardening. And our prime goal is to make sure patients are taken care of like they would be if they were our own family members. And we have all services starting from A through Z under one roof. So we are a comprehensive integrated center to help patients with spine, orthopedic, and musculoskeletal condition. Erin has been a part of a very good study that we have done to evaluate the clinical efficacy, safety, and functionality of functional restoration program. So without further ado, I'd love to give the baton over to Erin to discuss the study.
Thank you, Dr. Navani. Thank you very much. I'd like to share with you the results of a 3-year retrospective study that we did here at Boomerang. We looked at the functional restoration program and its components and the outcomes of our patients, specifically patients that were injured on the job that were managing their persistent and chronic pain. Before I get to our outcomes, I want to first talk about our functional restoration program. Since functional restoration programs vary, I think it's really important to talk about what we do specifically here at Boomerang and how we get the results that we get. Our functional restoration program is a 160-hour program. Our patients come 5 days a week. They come 4 hours each day. They come for a total of 8 weeks. Now, our FRP program consists of an interdisciplinary team. Our team includes physical therapy, chiro, acu. We have mental health therapists. We have nutritionists. All of these aspects are designed to specifically work with this population. We have work simulation. We work on ADLs. We work on a variety of gradual progressive exercises to improve the patient's functional abilities. We also work on the patient's thought process with regards to their pain. We use various techniques like CBT. We use psychoeducational classes, and we talk about sleep, pacing, and a variety of different things that really help patients be able to cope and manage their pain. We also speak about nutrition, talking about an anti-inflammatory diet, how important that is to rehabilitation. We talk about maybe comorbidity and how important that nutrition is to managing these other comorbidities that the patients have. We also have a medical management piece as well. So we talk about, we try to give the patient tools to manage their pain. So sometimes the patients, when appropriate, are able to decrease their medication use, and we use that medical management piece to be able to do that safely and appropriately. So part of our study, we looked at patients who were in the work comp system. So they all had to have a work comp case to be included in our study. As I said, this is a 3-year retrospective study. So it comprised of 484 patients total. We looked at a variety of things, but for our patients specifically, they were all, to be in the FRP program, they were all adults above 18 years old. And they had all completed conservative care, meaning that they have completed a trial and work in physical therapy, chiro, acu, maybe even massage. They've exhausted surgical interventions and maybe injection interventions as well. So despite all of these treatments, the patient was plateauing. And these are the patients that were included in our study in the FRP. Our study was conducted looking at our lifting capacities. So we took knee to waist lifting for our patients. We also used patient-reported outcome measurements to determine how the patient was doing. So for our patient-reported outcome measurements, we used the EC to look at insomnia. We looked at CSD to look at depression, and we looked at the GAD-7 to look at anxiety. We also looked at Oswestry scores as well. The results of our study was successful. Our patients completed the physical rehab portion and improved their lifting capacities. Now, for a lot of these patients, their ability to lift was the reason why they may not be returning to work. So this is a very important thing to look at. Now, when we took our patients, we looked at them before the program. We compared it to after our 160-hour program. Our patients on average went from 10 pounds to 26 pounds, with some of them even being able to lift up to 100 pounds after the program. The patient-reported outcome measurements also improved. We have increases on the CSD scores. Those scores they improved from 26 to 19.9. Our anxiety scores, they improved from 11.6 to 8.91. And our insomnia scores also improved from 17.83 to 14.69. Overall, our FRP program for these patients was very successful, being able to improve their functional capacities. Otherwise, they were completing conservative care and plateauing in their care. So this improvement was just an added bonus for these patients and, really, really encouraged them to continue their functional rehab after the program as well to maintain these great results. Thank you.